Hello everyone, and welcome to today's webinar. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Keith Hoots, and I'm the Director of the Division of Blood Diseases and Resources at the National Heart, Lung, and Blood Institute in HLBI, part of the National Institutes of Health. With you today for our presentation on the impact of public health surveillance on hemophilia care, being presented by Dr. Michael Soucie. I will be serving as today's moderator. We would especially like to recognize the Hemophilia Federation of America for hosting today's webinar. Before we get started, I'd like to go over a few points and helpful hints. First, upon joining the webinar, you will see two audio options. You can opt to listen via the speakers on your laptop, or using your phone, you can call in. If the phone option is chosen, the webinar toolbar will provide you with the phone and access number and audio pin. Number two, all audio will be muted at your end. At the end of the presentation, there will be time for questions. To submit a written question for Dr. Soucie, please use the questions area of your toolbar. Dr. Soucie will respond to as many questions as time allows. Third, today's webinar will last approximately 1 hour. Please note that this webinar will be recorded. Finally, we will begin today's webinar first with an audience poll of 3 knowledge questions. Please take a look at the following questions and cast your choice. The first question: which of the following are important differences between surveillance and a research study? A, data are collected using a standardized form. B, analyses of the collected data are done frequently. C, results of the analyses are reported on a regular basis to those who need to know. D, B, and C. Or E, all of the above are correct. Please vote your conscience before we move on to the next question. Okay, I think we can move on to question 2. A registry is a form of surveillance that is designed to collect information about a disorder. Which of the following public health attributes of a disorder can be studied using a registry? A, trends in the complications of a disorder over time. B, characteristics of the population affected. C, health resource needs. D, both A and B are correct. Or E, all of the above are correct. Please vote. So the final pre-test question is the following. A key aspect of public health is prevention. Which of the following are ways that surveillance can be used to support public health prevention activities? A, identify potential risk factors for complications. B, raise patient awareness of healthy practices. C, evaluate the effectiveness of preventive interventions. D, A and C are correct. E, all of the above are correct. Please designate your answer. So thank you, and we will revisit these questions at the end of this presentation. Now it's my pleasure to introduce our guest presenter, Dr. Michael Soucie. Dr. Soucie is an epidemiologist and has been working at the Centers for Disease Control and Prevention for 20 years. He also serves as the Associate Director for Science for CDC's Division of Blood Disorders in the National Center on Birth Defects and Developmental Disabilities. The focus of Dr. Soucie's work has been the development of surveillance systems for people with bleeding disorders. Analyses of data from these systems are used to assist in the development and evaluation of public health interventions to prevent or reduce the complications associated with these disorders. He is known nationally and internationally for his work in bleeding disorders. So, Dr. Soucie, let's begin.
Thank you, Dr. Hoots, and welcome everyone. I really appreciate the opportunity to talk with you about one of my favorite topics, which is public health surveillance. And I'm going to do it in the context of hemophilia care. So the next slide, please. So at the beginning here, I'm going to give a little bit of a brief overview of the clinical aspects of hemophilia and some of the historic aspects that are important in terms of the context for the surveillance that I'm going to describe. Second, I'm going to talk about public health practice in terms of both its goals of public health and the use of surveillance as a tool for public health practice. Next, I'll give a couple of examples of public health surveillance systems that have been established for hemophilia and other bleeding disorders. And finally, I'll illustrate the impact of public health surveillance on the hemophilia population in terms of two areas of critical importance, one being treatment product safety and the other joint disease. So hemophilia is a disorder, a congenital disorder, that results when there's a mutation in one of the genes that codes for one of the two coagulation proteins, either factor VIII or factor IX, that's involved in normal blood clotting. The deficiency of these proteins results in the lack of a strong platelet plug, and the result is a weak blood clot that does not stop bleeding. So the picture that you see there is, this is Queen Victoria, probably the most famous carrier of hemophilia, who through her extensive large family brought hemophilia into the royal families of several countries few years ago. And illustrates the fact that basically women carry the affected gene and will then transmit it to some of their daughters who can then bring hemophilia into other families. So the clinical classification basically is based upon the amount of the protein that is available to the person. So if the hemophilia person has less than 1% of the factor, either factor VIII or factor IX, then he's classified as having severe hemophilia. And the bleeding pattern is the most severe with, on average, about 2 to 4 bleeds per month. And the causes of these, they can just be spontaneous or due to trauma. On the other hand, if the level is 1 to 5%, you can see that the number of bleeds is much less and usually result from some trauma rather than a spontaneous bleed. And finally, in the mild area of 6 to 30%, bleeding is relatively uncommon and usually the result of either major trauma or surgery. There are variations in this so that some people with severe disease may not bleed as much, and those with mild forms may bleed more, which is not totally understood. But these are generally pretty well recognized classifications. The most common bleeding sites, particularly in small children, will be in the soft tissue in the form of bruises. But then once the person gets to be a toddler, starts walking around, they begin to have bleeding into joints, which leads to a chronic joint disease. So in terms of the historical aspect, it's really important to understand that even though hemophilia has been known for hundreds and even 1,000 years, the therapy, effective therapy for hemophilia has only been available for the past 45 years. In the early 1970s, the development of plasma concentrates, where large numbers of donations, thousands and even hundreds of thousands of donations, were then concentrated to get the small amount of factor VIII and factor IX that is in each person's bloodstream concentrated. And this allowed for the ability to be able to, for the first time, effectively treat bleeds and even prevent bleeds through home infusion. And in the mid-1970s, in 1975, a system of hemophilia treatment centers, which are comprehensive care centers set up in educational institutions throughout the United States, were established to provide comprehensive care for individuals with hemophilia in the proper use of these products. Unfortunately, these concentrates came with a price, because along with the factor that was concentrated, there was the opportunity for some of these hundreds of thousands of donors to have viral infections, such as hepatitis B, and what was first called non-A, non-B, but later identified as hepatitis C. A large proportion of the population became infected. And then in the early 1980s, in 1982, the first cases of what later became known as HIV were found in hemophilia patients, which really got people thinking that this must be a viral illness. At that time, it was not known what the cause. And here's where CDC came into the picture, primarily at the beginning to work on preventing secondary spread of HIV infection from the hemophilia males to their spouses, but also the laboratory here at CDC was involved in some of the first experiments, not only to identify the virus, but also to recognize that this virus was exquisitely sensitive to heat treatment, which allowed the treatment of these plasma concentrates and the inactivation of the HIV. Unfortunately, because of the long incubation period for the HIV infection, already by that time, a large proportion of the hemophilia population had already been infected, and there was continued work on enhanced viral inactivation procedures, primarily for the hepatitis virus. But again, by the time these products were developed, or these processes were developed, nearly 75% or so of the population was infected with hepatitis C. So Congress shifted the focus of the activities in this area to prevention programs, and this is where we were in the early 1990s with the public health needs of the hemophilia community. So we needed to have some estimate of the size of the population. There was no registry or no place where people with hemophilia had to sign up, so we really had no idea of the size of the population. We needed to have some idea of the rates and the severity of the complications, not only those of infectious diseases I've already mentioned, but also the extent of joint disease. We needed a description of the treatment and care patterns of patients in terms of their receiving comprehensive care or other types of treatment. And we needed a system, obviously, to monitor blood product safety so that the AIDS epidemic in this population would never be repeated. So at this point, I want to just step back just a second because I'm using the word public health quite a lot. And these are definitions from the American Public Health Association of Public Health. And public health is prevention. That's a real key issue. And here at CDC, even though we don't have a P in the CDC, there is. It's Centers for Disease Control and Prevention. We really are focused on prevention. And we practice this preventing disease and promoting good health throughout the population. It's also one of the tools of public health is surveillance, or population health surveillance. And that's what I'm going to focus on next. So what is surveillance? And I think really the best definition that I've ever seen, and the short and simple, to the point, ongoing collection, analysis, and dissemination of health-related data. So ongoing is a key feature to provide information that's used to monitor and improve the health of the population. Effective surveillance has to have well-defined objectives. We have to collect data in a standardized fashion, frequent data analysis, and dissemination of the results to people who need to know. And this really is the difference between surveillance and research. We do collect data in a standardized fashion in both, but usually in research we'll just do the analysis one time, report the results of the research, and that'll be it. But surveillance is really an ongoing process of continued data collection, frequent data analysis, and dissemination of the results. Many of you may have heard the term registry. A registry is a form of surveillance that's designed to collect information about a disease in terms of its occurrence, the type, the extent, and the treatment received. And they're designed to monitor disease trends over time, to determine disease patterns in various populations, who are people who are at risk for this disease or for complications of that disease. And they're used to guide planning and evaluation of disease control programs. In other words, sometimes we want to evaluate whether or not a prevention effort that we are sponsoring is having the desired effect, so we'll continue to monitor. We'll also use it to help set priorities for allocating health resources. And also, it's a good platform to be able to advance clinical, epidemiologic, and health services research. So the first surveillance system that I'd like to describe for hemophilia was called the Hemophilia Surveillance System. And it was an active registry in 6 U.S. states. And by active, it means that it was actually, the whole purpose was to identify all persons with hemophilia in those states. And we had people who would actually go out and look. It was an active surveillance effort to find every person with hemophilia in those states. It was operated as a cooperative agreement with the state health departments of those 6 states. And the reason for that is that the health departments have the authority to be able to review medical records without individual consent. And this is not so that we can find out information about people that they don't want to know, but it's the ability to be able to look at information about patients who have disease and not have to worry about not being able to look at some and therefore missing the count. So basically, the health departments have this authority, and the information that they collect that's personal identifying kind of information stays within the health department and is not transmitted to the CDC as part of these kinds of projects. The search for hemophilia patients extended not only from these hemophilia treatment centers, but to doctors' offices, emergency rooms, hospitals, and even to medical testing laboratories where the tests for hemophilia were performed. And we also obtained death certificates. So what did we learn from the hemophilia surveillance system? We learned that the prevalence was about 1 in 7,500 males in the United States, which works out to a U.S. population in the mid-90s of about 17,000 people with hemophilia. We also found through the collection of death records that there was a reduced life expectancy primarily due to the HIV exposure. 65% of the deaths during that time were due to HIV. We also had deaths due to intracranial hemorrhage, which is a serious complication for people with hemophilia. You can see that the 18.2% death rate. And we found out that they were associated with some other complications, including inhibitors, which we'll talk about in a little while. Compared to the general population, hemophilia patients were at increased risk of death from cancer, liver disease, and renal disease. We also were able to look at the effect of the specialized care system that had been established in these hemophilia treatment centers. Because we found all patients in these states with hemophilia, including people who were receiving care in the hemophilia treatment centers, as well as those who were not, we were able to compare some of these outcomes in terms of both mortality and being hospitalized for a bleeding complication. People in hemophilia treatment centers were much less likely to have these outcomes. So this was a really important step in understanding the burden of hemophilia in the United States, not only in terms of the numbers of people that may have been affected by hemophilia, but also to learn something about the complications being experienced. We next turn to a second surveillance system that I'll describe, which we refer to as the Universal Data Collection System. This was a medical registry that was established in the hemophilia treatment centers at the request of the hemophilia community to provide surveillance regarding both the safety of blood products used to treat hemophilia, as well as trying to prevent joint disease and other complications of hemophilia. The participants received care at HTCs and provided a blood specimen for viral testing, and the HTC staff provided other data on both care and outcomes of that care. This is a map showing with the stars there, you can see these federally funded hemophilia treatment centers. They pretty much follow the population centers of the United States. So the patients receiving care in these treatment centers with congenital bleeding disorders were eligible to participate in this surveillance, of which there were three components. The first was education about the surveillance, the purpose for it, and getting their informed consent, because it was a voluntary program. And again, making sure that patients understood that no identifiers were being sent to CDC. The data were collected by HTC staff using standardized data forms, and a blood sample was drawn, as I've already mentioned, for viral testing and also for serum storage. And I'll show you some examples of what we did with that information in a minute. So first, in terms of blood product safety. So the testing that was performed here at CDC was for the hepatitis viruses and HIV, performed centrally at our lab, and any new infections that were confirmed with a repeat test on a second specimen were then followed up in an investigation. So complete information on all blood and blood product exposures were obtained, and an epidemiologic investigation was conducted by the State Health Department with the CDC assistance as necessary. And the purpose of this investigation was to make sure that the new infection was not obtained through the use of a blood product or a blood treatment product. In January of 2003, we reported the results of the first 5 years of this monitoring through the UDC system. So on the basis of testing more than 11,000 people with bleeding disorders, no new infections with hepatitis or HIV attributable to the use of treatment products were found. This is what I mean by dissemination of the information that you're collecting as part of your surveillance. So the other thing that I wanted to do in terms of infectious disease is I wanted to tell you about an investigation that we did using the serum specimens. You recall that we tested one part of the specimen, and we also maintained a serum bank with the remaining specimens. And the reason we did this was to be able to, if a new virus happened to come along or some other infectious disease, we would have specimens to be able to go look back and look at these specimens to see if that infection was getting into the blood supply and into hemophilia patients. So as an example of one of these investigations, we were looking at parvovirus B19. This is a very common childhood infection. All of us have probably had a parvovirus B19 infection when we were a small child, and it usually was just passed off as another infection that we had, another cold or whatever. Most of the time, as I say, it doesn't really cause problems for small children, but in adults, it can cause an acute or chronic arthritis, especially in women, and it can cause fetal death in pregnant women. It's also been reported to result in a fulminant hepatitis in certain populations. So why am I talking about this? Why are products at risk from this kind of infection? So it has all the qualifications of something that could get into the blood supply, and that is the large percentage of the population are exposed to this virus, and once exposed and once you have the infection, it causes high levels of the virus in the bloodstream. So there's also evidence that people can be chronically infected with this and be totally asymptomatic and therefore eligible to donate blood. The virus itself is a non-envelope single-strand DNA virus, and these kinds of viruses are relatively resistant to the viral inactivation methods that are used to make the product safe. They're also extremely small sized, and while most currently available products are not routinely filtered, even if they are, the size is not adequate to catch these viruses if they're in the product. And finally, there were available data that provided evidence that B19 was able to survive the fractionation and inactivation procedures for products. So what we did was we took blood specimens from 800 patients born after the licensure of recombinant products, and recombinant products, by the way, are products that are made not from plasma, but made by recombinant technology and are not susceptible to infections. So the age ranges of these study subjects were from 2 to 7 years old, very young because, as I mentioned, parvovirus B19 is present in the community, and most people get exposed when they're very young. We tested the samples. These are samples that we had previously saved in the serum bank. We tested them for exposure to parvovirus B19. And participants who had never used blood or blood products served as control. So these were the people from the community who'd never received blood products. So they would have the most average level of exposure to this virus. And so then what we did was we compared the prevalence of the exposure in the virus between the different product groups. So these are children, again, born before, all born before 2000. And you see that the reference group here is those that received no factor or no blood or blood products. And then we have children who received only recombinant product. And you can see that their risk of having been exposed to this product is no different from those who've never had any product at all. However, when you look at the children who've been exposed to both recombinant and plasma-derived product, you can see that those children were twice as likely to have been exposed to pyrovirus B19 than those who had not. And finally, those children who had been exposed to plasma-derived products only were nearly 8 times more likely to have had previous exposure to pyrovirus B19, which suggests that these patients were getting exposed to pyrovirus B19 through the product. So in 2000, the manufacturers began a voluntary plasma mini-pool nucleic acid testing screening. So what this amounts to is that a special test is applied to the pools that go into making these products, looking for pyrovirus B19, and if found, the product is not further manufactured into a plasma-derived product. So an FDA study found that this screening had lowered the levels of B19 in most products, but no study had evaluated the effectiveness of this screening process on preventing infection. So in 2010, using UDC specimens collected from another 1,000 children who were born after 2000, we repeated the earlier study. So here is the same table as before. Now these are children born after 2000. And you can see, once again, with the recombinant product, there was no difference between those and the people not exposed to any product. And then the plasma-derived, in this case, and recombinant, there was still no increased risk. But we saw a little bit of an increased risk still for the plasma-derived only. It's actually highly statistically significant, but it's essentially suggesting that perhaps there's still some exposure through plasma-derived products. So this is an example of how we used the specimens collected as part of the surveillance system to be able to not only take a look at a potential problem in the community, but also to measure the effectiveness of an intervention put in place to potentially prevent that complication. So other monitoring results were that we had no new infections with hepatitis A, B, or C, or HIV were attributed to blood or blood product exposure during the entire period that the UDC project was in place. We also collected data on small children about vaccination, especially for hepatitis A, which wasn't common back in that period of time. And we've found that the vaccination rates had improved over time. And after the MMWR article that I mentioned, we continued to disseminate these findings in routine surveillance reports, providing reassurance of product safety to the community. So I'd also like to give you a couple of examples how we've used surveillance in this issue of joint disease. So the data that we collected as part of UDC on joint disease included some clinical measures, including joint range of motion measurements by trained staff, data on all orthopedic procedures, including joint replacements, and the number of joint bleeding episodes. We also collected data on some functional measures, including days lost from school or work due to joint problems, self-reported activity level that may have been limited by joint problems, and the use of assistive devices such as canes, walkers, and wheelchairs. In August of 2007, there was a landmark study result reported in the New England Journal that showed, for once and for all, that prophylaxis, in other words, treating people with factor concentrate before having a bleed and trying to prevent all bleeding, was actually shown to prevent joint disease in young boys with severe hemophilia. So what we were able to do was using information from the The slide's not showing up correctly. All right. So I'm going to go back to this slide, even though you can't see it. I'm going to have to describe it. Essentially, what we were doing was looking at the trends in prophylaxis use and the bleeding events in patients aged 10 to 19 years with severe hemophilia from 1999 to 2010. And if you could see this slide, I'm sorry you can't see it, there you would see that the rate of prophylaxis use was going up and that bleeding events in the patients were going down over this period of time, and that around 2007, between 2007 and 2008, you could see an increase in the rate of the increased use of prophylaxis, letting us know that the information that we were sending out on prophylaxis was having a desired effect. This slide, fortunately that we can actually see, I apologize for that, shows all invasive orthopedic procedures in all joints during the period of time 2000 to 2010. So in this slide you can see that the proportion of individuals having invasive orthopedic procedures went from a high level in 2000 down to a much lower level in 2010, showing that basically the going along with the idea that more people were using prophylaxis, more people were preventing bleeds, and the bleeds then were not causing the joints to have problems, and these orthopedic procedures were less likely to be needed. So that's how we use surveillance data to monitor what's going on, trends in outcomes and so forth. We can also use surveillance data to actually perform studies to look for risk factors for these outcomes. So in this particular example, I'm going to tell you about a study that we did looking at risk factors for joint range of motion limitation. You recall that I mentioned that we collected data on how well the joints moved, and this is called range of motion. Basically, we did analyses and we identified that increased body mass index was a strong risk factor for increased rate of joint range of motion loss. Furthermore, the UDC data indicated that nearly a third of U.S. teens and children with hemophilia were either obese or overweight. As you all know, there's an epidemic of obesity and overweight in this population, and it did not skip over the hemophilia population. So I just wanted to show you a little bit of data from that study. So what you see on the left side over here, basically on these left axes, are the proportion of the normal range of motion that a person would have. And on the x-axis here, we have the age of the individual. So again, these are from 2 years old until to 19 years old. And what you can see here is we have three graphs, one for people with mild hemophilia, moderate hemophilia, and severe. And there are three lines, one for normal weight, overweight, and obese individuals. So you can see in every severity that for individuals who are overweight or obese, that the rate of range of motion loss is greater for those who are overweight or obese. So what do we do? So we also collected information on some of these other outputs, attendance at school or work and physical activity. And you can see that on average, the overweight individuals had more days missed per month on average due to joint problems, and a higher proportion of overweight individuals reported any activity restriction due to joint problems. So what do we do with this information? So it's really important that we raise awareness about this as a possible prevention step. And here's where prevention research takes over and surveillance leaves off. So prevention research is involved in awareness campaigns and also developing interventions. So an example of an awareness campaign is the Do the 5 program that the National Hemophilia Foundation put on. And you can see that these 5 recommendations here are along the lines of public health: getting vaccinated, going to your HTC and having a checkup, early and adequate treatment of bleeding episodes. And you'll notice here in number 4, regular physical exercise. Prior to this study, it actually said regular physical exercise to strengthen joints. And you can see that we've modified that and maintain a healthy weight to be able to get this information out, make people aware that obesity or overweight was a risk factor for increased joint damage. In terms of interventions, our partners, the Hemophilia Federation of America, developed the Fit Factor program, which is a strength, flexibility, and wellness program, which was designed to promote physical activity and healthy weight maintenance for people with hemophilia. And the National Hemophilia Foundation Steps for Living, which is an education program for all life stages, has materials in terms of games, quizzes that are directed, they're age specific and targeted again towards healthy practices at each stage of life. So these are tools that the intervention steps then that are used to get the information out to the public, to the hemophilia patients, and then through continued surveillance we'll be able to monitor the impact of these programs on this, on eliminating this problem. So I want to sum up a little bit the public health surveillance outputs from this program to help monitor trends over time in terms of the hepatitis and HIV infections that I mentioned, identifying risk factors for poor outcomes, the obesity and joint disease example that I gave, developing interventions and assessing the effectiveness, to conduct blood product safety investigations. And we were also able to utilize GIS that's Geographic Information Systems, to identify patterns of care, inform outreach efforts, and link people to care. So this is a slide of the males with hemophilia in the United States. Each one of these dots is a male with hemophilia. And you can see it's overlaid on the stars that represent the hemophilia treatment centers. And furthermore, the dots are colored to indicate which treatment center they're receiving care. And I would just point out this one here in Denver, and you can see that they're taking care of patients in a wide geographic area. And use of these kinds of maps, especially on a regional level, was very useful to the regions in being able to allocate resources to places where patients needed to have them, and for other allocations in those kinds of projects. So I wanted to briefly mention a new surveillance activity that's based on evaluation of the UDC. We need to evaluate our surveillance systems on a periodic basis. And based on feedback we received from the community, a new surveillance project was begun at the end of 2013, which is a collaboration between CDC and the hemophilia care providers. And there's 3 components: a population profile, which is a counting of all the patients receiving care in the treatment center, mortality reporting, and a registry, much like the UDC, which is now called Community Counts. key registry components. It continues to have product safety with targeted infectious disease testing, and we've also expanded now to central laboratory testing for inhibitors, which is an antibody to the products and is a big product safety issue these days. In terms of joint disease, we're collecting more detailed information on bleeding frequency to help inform Healthy People 2020 goal to prevent joint disease, and some emerging issues in terms of healthcare use and chronic conditions. As the hemophilia population is aging, they are developing more chronic conditions, and we needed information on this. So I hope that I have given to you some reasons why surveillance matters. It supports a broad public health program, a powerful health outcomes data collection network. It enables large numbers of observations on people with rare disorders and supports improvement in standards of care for bleeding disorder populations. And it really has the capacity to expand to support surveillance on other rare blood disorders. I'd like to acknowledge the patients with hemophilia for their willingness to participate in these surveillance activities, staff in the U.S. Hemophilia Treatment Center Network for promoting patient participation and collecting the data, and to the Hemophilia Federation of America for their assistance with this webinar. So at this point, I'm happy to take questions.
Okay, we've received, this is Keith Hoots again, we've received a couple of questions already. First question, is Zika virus transmission a problem with those who receive blood products, and can viral inactivation eliminate it?
That's an excellent question, and it was one of the first things, obviously, that we thought about. Now, so the Zika virus is a flavivirus, which is in the same family that West Nile virus was, and these particular viruses are inactivated by the current procedures. And so most of the concern and around this has to do with populations that receive blood transfusions. And so that's where most of the energy is being directed to prevent spread of this virus.
Okay, second question. Since there have been no viral transmissions in plasma products in many years, does the CDC still do surveillance for that?
Yes, and you'll notice that in the new surveillance system that I mentioned, that we're doing targeted surveillance, and what that means is that we're doing testing, the viral testing that we were doing on the basis of whether or not people were exposed to products in which they may contract these infections. So it's more of a targeted approach, but we're continuing with that effort.
Okay, those are the questions that we've received so far. So if you have questions, please type them in now. Okay, the next question. What is the estimated percentage of people with hemophilia who do not attend hemophilia treatment centers and are not counted in surveillance data?
Well, the data that we have about that is goes back to the first surveillance system that I mentioned. At that time, it was about 30% of patients were not receiving care in the treatment centers. However, we've not been able to repeat that same study since then, but we have begun some investigations working in a couple of different ways with our partners to try to get a more current estimate of that. So we will be, we're at the stage where we're going to be able to start doing some analyses with the data that have been collected, and we should have a better idea about that in the near future.
Okay, we have a procedural question. Are we able to get this slide presentation to share with our staff as education?
Certainly.
Okay, I think probably the the organizers of the webinar will know, they know exactly who signed up, so we can make that available.
I say certainly in terms of I'm happy to share them, and I presume that they'll have the ability to be able to send them out.
Okay. The next question is for hemophilia treatment centers where hepatitis B, HCV, and HIV is annual standard of care. When CDC receives blood specimens, do you test again for additional reporting purposes?
Well, the way that worked was that the testing was provided as part of enrolling in the surveillance. In other words, we were providing the testing at no charge, either to the person's insurance company or otherwise, and that continues to be the case. So we wouldn't necessarily repeat testing, but it was known to the treatment centers that we would provide this testing free of charge.
Okay, so in follow-up to the question about the availability of the slide set, you want to make sure everyone is aware that this webinar is being recorded, both audio with the slide set, and they will be available and posted to both the Hemophilia Federation of America and the CDC websites. Another procedural question that I may have to ask for help on is, are there certificates for attending this webinar?
I'm told that there are not.
Okay, so the next question is, what % of hemophilia patients still receive blood product factor as opposed to non-blood products?
I don't have that number right off the top of my head, but my sense is that the vast majority of patients, particularly the younger patients, are almost 100% probably on recombinant products.
Okay, I think those are the last of the questions that I've received. So I think what we can do is go back to the pre-test questions and have you re-answer the questions if you, or for the first time if you didn't do it the first time through, and then Dr. Soucie will come on to give you the correct answers for these questions. So the first, again, I won't read all the answers this time. I'll just read the questions. Which of the following are important differences between surveillance and a research study? Please select one. And once we've given you a second, then Dr. Soucie will give you the correct answer.
You want my answer now?
Sure.
The correct response was D, B and C.
Perfect. Okay, the second question is, we'll pull it up on the screen. Which of the following public health attributes of a disorder can be studied using a registry? Please select one of the following. Okay.
And the correct response was E, all of the above.
Okay, perfect. And the final post-test question, which is the same as the pre-test questions, is the following. Which of the following are ways that surveillance can be used to support public health prevention activities? Again, please select only one answer. Dr. Soucie?
And the answer is D, A and C. As I mentioned to you, the raising patient awareness in healthy practices is part of prevention research.
Perfect. So as the moderator of the webinar, I would like to now thank you for joining us today. If you have any additional questions about today's presentation, please contact Dr. Soucie directly. His email is M_Soucie @cdc.gov. This webinar will, as I alluded to before, be archived, and the content will soon be available at CDC's Division of Blood Disorders website at the following address: http://www.cdc.gov/ncbdd/webinar.html. Additional questions about this webinar series can be sent to Cynthia Sayers at C Sayers, SAYERS, all one, at cdc.gov. Please be sure to join next month on March the 3rd at the same time for the next scheduled webinar when Dr. Alex Spiropoulos will present on assessing the risk for venous thromboembolism in hospitalized medical patients. Again, thank you for your participation, and good afternoon.